on my speech. I will. Yeah. I have. Okay. It's for Shawn. Okay. Great. Shawn, yes. Hello, everyone. My name's Shawn. Yep. Welcome. So, I'm ready. Oh, sorry. He said we were going. Where it go? Yeah. All right. The stream has started. Where it go? So, welcome everyone to my topic. I am really excited to be here. Today, I wanted to talk to you guys about specialized roles in healthcare advocacy. And what I mean by that is specializing in the way that a physician specializes. So I'm from the University of Utah Huntsman Cancer Institute, and that's kind of what we've built for a healthcare advocacy model at our institution. And I'm just going to try to, well, my thing's not going, try to walk you guys through this. And basically what I want to do today is to help you guys understand the advantages and disadvantages of using a specialization model, to describe the current process that we employ at Huntsman, and then to demonstrate the process and how to achieve success in real time. So I'll have like a sort of case report and a poll associated with that at the end. So this is what we call ourselves. This is an advanced role for pharmacy technicians at the University of Utah. We call ourselves the Medication Access Coordinators, MAC for short. And here's our team. You can see we've divided it into hematology, and then in a minute I'll show you my oncology, medical oncology associates. But on the bottom left here, you have Adam, who is our BMT and amyloid person. He also works with our supportive oncology services clinic to help with like anxiety management, pain management, things of that sort. Diagonal from him is Colleen. She is our myeloma expert, and that clinic is one of the biggest in the hospital, which is why that's pretty much all she does. And then below her is my colleague Nicole, who works with the Leukemia and Lymphoma clinics, also does work with myeloproliferative neoplasms and thalassemia. There's a few other smaller disease states, rare disease states that are in there, but this is her focus. And then lastly, in hematology is myself, also leukemia, lymphoma, and then I specialize in our bleeding and clotting disorders clinic, which is like hemophilia, thrombocytopenia, things of that nature, platelet dysfunction. And then with our oncology team, up there in the top left, we have Colby. He's our prostate and genital urinary guy. Next to him is Dan. He's works with our GI clinic for like colorectal cancer, anal cancer, things of that nature. Diagonally, we've got Aaron here. He works with our ear, nose, and throat team, the thoracic team, and a little bit of GI, just because that's also one of our large clinics in the hospital. And then there on the bottom is Skylar. She's our breast and gynecology specialist. And then lastly, we have Jocelyn there on top. She's our melanoma and sarcoma. And Zach, who's actually here today in the audience, he's our supervisor and also works with our neurology clinic on brain tumors. So before we really get into this, I wanted to give you guys a little bit more background about how this team sort of formed. And really, in a sense, it just was it was the hospital leadership that sort of came to the pharmacy department and were asking questions about how we could shore up some of the losses they were seeing. You know, previously to this team taking over authorizations for our infusion center, we the MAC team was only authorizing oral medications. So a lot of like BTKIs for leukemia, like Sprycel or imatinib, Gleevec, or on the solid tumor side, things like Mekinist or Zytiga. And then we were also helping to support our outpatient pharmacy by performing prior authorizations for drugs that would be filled there as well. But when hospital leadership started looking for ways to help shore up some of the losses we were seeing through infusion, they approached the pharmacy department, and you know, it was a long process. We actually had a pharmacy resident do a project to help us sort of set this up. And what we agreed on was to have the MAC team take on all of these medical prior authorizations. This, of course, required some infrastructure improvements with regards to our own prior auth request, our previous smart phrases that we were using. I don't know, we use Epic at Huntsman. I don't know if anyone else is familiar. Use what? Epic as an EMR. And so we made a bunch of smart phrases within Epic to help us sort of gear more towards the infusion setting rather than the oral oncology setting. And the primary aspect of this was our benefits investigation, which it looks pretty bare bones, but it really serves its purpose pretty well at our institution. It tells us what the drug is, who the insurance is, what the patient's insurance information is, including effective to and from dates, any HCPCS codes that are being billed, and then the patient's medical benefits there at the bottom, and then places to put our references and sources and any ancillary information. But in addition to the benefit investigation, and I apologize, I don't have time to go through our whole process in detail because of time, but we also have smart phrases for the submission. We have smart phrases for the approval of a prior authorization. We have smart phrases for a denial. We have smart phrases for filing appeals. And then in addition to that, we also have, for patients that we identify a financial need, we also have a whole different set of smart phrases for signing them up for copay assistance or patient assistance programs or grant programs, through third parties, things like that. And so this is what we spend our days doing, is filling out these dot phrases to ensure that we are making sure patients have coverage, making sure that coverage is going to cover their therapy, and if it doesn't, finding access to ways they can still receive it. The reason we chose pharmacy technicians, again, there was already a smaller team dedicated to the oral oncology sector, and they were doing a great job, basically, and it seemed like a sort of natural progression to ease them into this. So and in addition, we have, pharmacy technicians already have a pretty good idea of the insurance landscape, especially local payer landscape, where a lot of other medical professionals I find know pretty well what to expect from like a big payer like United Healthcare, but they don't necessarily know what to expect from someone small like Select Health, which is our Intermountain Healthcare program that's local to Salt Lake City. Um, it offers an advancement opportunity in a limited career fields. Pharmacy technicians, once they reach journeyman or master level, there's not really a lot of upward growth there, and that can be frustrating for people who are driven or who want to succeed in other ways. So this offers that. I don't think when I started back in 2005 as a pharmacy technician in a retail pharmacy that I would be doing something like this, but it impacts people in such a significant way. You can impact people at a retail pharmacy, and I don't want to demean that profession in any sense, but it can be so impactful. We have discussions with patients where they are crying like their thank yous to us on a regular basis. So it's really rewarding for us in that sense as well. We also come prepackaged with HIPAA training. We get to do the same modules, every year over and over. But it does make it's kind of an appealing option because we already come with that built in. We can offer support to our clinical pharmacists in ways that aren't the same as you would in a retail setting, but we are there to sort of help them accomplish things, especially if they have an urgent need. We can sort of drop everything and just focus on that for them. And I know that they really appreciate that. And then we work as a really good liaison between our outpatient, our inpatient, and our infusion pharmacies. So we have direct lines of communication with them. We email back and forth all day. And because it's all within the University of Utah umbrella, all those communications are already secure. So we're not waiting for faxes to come in and go out, for instance, when we're dealing within the institution. Um, After we got this project off the ground, we started noticing some retrospective advantages. People were noting faster turnaround times for prior authorizations as well as patient assistance enrollments. There was better communication with the clinical care teams. If after we started to really understand our diseases, our assigned diseases, it was really easy for us to say, okay, I can do this, but the insurance is probably never going to pay for it. So you're looking at some additional time to see if we can apply for free drug programs or something like that. It offers that sort of upfront picture for the clinician so that they know what to expect on their end. And if they don't want to wait that long, a lot of times they'll change therapy because they simply don't want to wait. And other times they're like, you know what, we've got some time, let's do it. Um, we we started getting the increased claim capture rate, which was one of the things that sort of led to the formation of the team in the first place. Um, and we had, as a result, a decreased number of post-service appeals, as well as a decreased write-off amount. When we first started, we would meet regularly with our revenue cycle team to discuss denials and why they happened. And it was very much sort of an inquisition in a lot of senses. There was a lot of, why didn't you do this? Why didn't you do that? Why isn't there an authorization on file? And we had to say, well, actually, all of these other factors played into that. And I did advise not to proceed with this infusion, but after we started noticing this, the dropping number of write-offs and post-service appeals, revenue cycle stopped contacting us for those meetings. They just stopped. And Zach will attest to that. We do get a write-off list of things that got written off, and we go through that, but we sort of hold ourselves accountable. We don't hardly ever meet with them anymore, which I think is a very telling result. And then we were able to identify more opportunities for financial aid, like copay assistance for patients, because we had a little bit more time, a little bit more breathing room to meet with more people. And so, people came to look at us as sort of an angel for them in the sense that, yeah, they might have a 20% coinsurance, but surprise, we're able to enroll you in this copay card for rituximab, and we're going to wash that all away. That was a really big thing we were able to do. And then, as I mentioned before, it allows us a lot more breathing room to handle urgent cases. I get almost every day a request from one of my clinic pharmacists for a drug called Neulasta for white blood cell regeneration after chemo. And because I have a built-in knowledge of the payer landscape, as well as the urgency of the need, I can almost always advise which product to give because there's about, I think, half a dozen different biosimilar products available now. So I'm able to advise which product to give, if it's okay to give it today or if we have to wait to get that approval in place. And that's a huge burden lifted off of the pharmacists who are anticipating fighting with a clinician over holding, life-saving drug. So, these are just, like I said, retrospective advantages. The main goal was just the write-off issue that we had previously. And that's not to say that there aren't some disadvantages. In the interest of full disclosure, we do have difficulty covering PTO. So we had a lot of emails yesterday come in because me and Zach are out, and people really stressing about what to do about some of those emails. But at the end of the day, they were able to work through most of them pretty efficiently. And if I'm sorry, yes. So that's for paid time off. So people who are out of the office on vacation or here at a conference like we are. Um, it's because we have a cross coverage setup, but again, there's just innate knowledge that happens with working with certain providers on certain diseases regularly. And if you're not the person working with those providers, there might be some communication breakdowns. Sometimes, I'm the bleeding disorder guy. No one else knows about the bleeding disorder community but me. And so when I'm out, it takes them a lot longer to navigate prior authorization issues or specialty pharmacy issues, things like that. Whereas I have direct contacts, which I share, of course, but I've already built those professional relationships, and it's a lot easier to navigate for me than it is for any of my coworkers. So that is one limitation. It was also a steep learning curve. I came into this position having almost no knowledge of the hematology oncology sector, because these are all specialty pharmacy or infusion medications. And working in a retail setting, for instance, I had no contact with them at all. So that is something to keep in mind. The reporting structure is kind of confusing sometimes. If a clinician is mad because I say no about something, they're going to go to their clinic pharmacist who's going to come to me, and they're going to say, why did you say no? And I'm going to say, well, because I know that this payer is going to deny that drug specifically for that indication. And then the clinician and the pharmacist may both go to the pharmacy director, who I then have to have a third conversation with and explain my rationale. And what ends up happening usually is that I get overruled, and that may be okay. At the end of the day, I may get that approved and I may not. So, but it's out of my hands. But it does create a sort of time suck because I'm explaining the same case to 3 or 4 different people along the way. Off-label requests for medications that are used in different disease settings can be challenging to navigate because I don't interface with them. A good example for me is the medication Keytruda. It has something like 30 or 32 approved indications for treatment, but only 1 or maybe 2 of those are for lymphoma. So I don't interface with it very much. So when I see their clinical intake form, which is I think 4 or 5 pages now, it's a little daunting to me. I have to go to Jocelyn, or someone in the solid tumor group and say, so what do I do? Which pages are necessary? Where do they sign? So that just takes a little bit extra time. It's not that it's not navigable, but it's just a little bit extra time than if it were something that I'm familiar with, like Sprycel or like Promactiv from Novartis. They have the best service request form in the industry, in my opinion. So it does sort of lead to that extra time suck, which can be annoying to providers. And then just different clinicians and their attitudes, professionally or personally, can sort of play into this a little bit. I work very closely with a short list of providers, and we can speak to each other in a way that Nicole, who's my coverage counterpart, may or may not be able to. She's probably not comfortable being as upfront and blunt as I am. So that can be a little bit of a problem. And case in point, so this is a real thing that happened to me. Dr. Stevens, I love her to death and she cares about her patients, but she sent me this email.
Can you define those?
I will, yes. So this is just so you guys have a little bit more baseline knowledge. And I've changed the name, obviously, for HIPAA, but Mrs. Jones was a 54-year-old female with previous medical history of chronic lymphocytic leukemia, immune thrombocytopenic purpura, and factor V Leiden, which is like a hypercoagulable syndrome where patients make clots when they shouldn't. An ITP is just a low platelet count. So Dr. Stevens sent me, and this is word for word again, apart from the patient's name. Shawn, can you get nivolumab for Mrs. Jones due to Richter's? McKenna gave her a heads up that you may be contacting her. Now, how many of you guys know what Richter's means? Anyone in the room? Raise of hands. Okay. So the only reason I knew what Richter's means is because I specialize in hematology. Richter's transformation is when a patient's CLL transforms into diffuse large B-cell lymphoma, which is a very aggressive, very deadly form of lymphoma. It can still be curable, but it is very dangerous, and time can be of the essence, especially for this patient who has, as you can see, and I want you guys to assume, we have a poll coming up, and I just want you guys to assume that you know this and understand it for the purposes of the poll. But so the patients receive 6 lines of therapy to treat CLL. That's a lot. Chronic lymphocytic leukemia is chronic, and usually patients who are placed on therapy can remain on that same therapy indefinitely with no disease progression. Occasionally, patients' disease changes, they have new mutations, and they lose response to that therapy, and then we change to another line. So the fact that she's been through 6 lines of therapy is pretty egregious. Richter's transformation, she had actually transformed a few lines of therapy before this email, but it was getting worse. So she also had the CLL going on, but part of that CLL had now gone into her lymph nodes and other organ sites, and it was getting worse. At this time she had had a PET CT scan that showed diffuse involvement all over her body. I mean, everywhere. I don't know if you guys have seen a PET CT, but they light up areas of high metabolic activity in the body. and she looked like a light bulb. It was really sad. Um, the nivolumab itself is considered off-label in this treatment setting. It's not approved in diffuse large B-cell or in CLL, but it is on the NCCN recommendations, but only as a category 2. Additional assumptions: the patient is commercially insured under a Cigna policy. She most recently received CAR T therapy, which is managed by Cigna's Transplant Care Coordination Program, and the patient's disease has been progressing at an alarming rate. So time is of the essence. So now this is where I want you guys to sort of participate in the discussion. What is your first step? And there, sorry?
How would check what stage the patient
So
is to begin
the
with?
diffuse large B cell is stage 4,
Okay.
but CLL isn't staged in that classic Ann Arbor way. So it's just considered chronic. That's the stage. But any of these is a reasonable option, I'll add. One of them, if you know all of this history and you know the patient and you've worked with Cigna before, one of them is an obvious answer to treatment same day. I'll give you guys a couple seconds to think about it. And we'll see if our online participants have jumped into the conversation. It doesn't look like anybody has. But in this case, because she has Cigna insurance and she was previously enrolled in their transplant care coordination program, she was still enrolled. And I knew that because I had spoken to her case manager a couple of days before about a different therapy. And so I simply called her up again and said, Dr. Stevens wants to do this today. Can you put in an authorization for it? Because patients who are approved in that program, Cigna wants them to live. Contrary to how we often feel about insurance companies, they actually do want their patients to do well clinically. And so they will pretty much approve anything as long as it is listed in any reference material. So micromedics, NCCN, regardless of the category. So if it's, if there's like almost no clinical evidence, as long as it's mentioned in some sort of nationally recognized compendia, they will approve it. And so in this case, I think it was Sydney was the case manager I spoke with. She approved this patient to receive that medication, the nivolumab, and she had met her out of pocket, so I didn't need to do a copay assistance card, but she was able to be successfully treated. Unfortunately, she then went on vacation with her family and got hospitalized out of state and was not able to continue those treatments, so she did pass away, but we were able to get her started on therapy at any rate. And at this point, we don't have much time left, sorry, but if there are any other questions, I will field those.
I'd like to know what you do when you hit a wall.
Nate, do you have a specific wall in mind?
Let's just say that, again, I don't know too much what you do because I'm not in your particular business. But let's say that you're, trying everything you can to get somebody the assistance that they need and just strike out. What do you do with it?
So that has happened before. I've been desperate a few times, and I mean truly desperate. I was working on a renewal for patient assistance through the Novartis Patient Assistance Program several years ago, and I had this patient who I knew was out of medication, and she was very nervous about it because she has been in remission for her thrombocytopenia for many years, and she was worried that if she went off, she would have a relapse. And that put a lot of pressure on me, and the provider wasn't offering me any suggestions or alternatives to try. The program itself was the issue. They had changed vendors that year, and of course, I'm sure some of you have experienced that. Vendor changes mean they always send out an email or a fax or something that says this is we're going to take care of this, and there will be no interruptions in care, and there almost always are. So the patient's application had been sent in for renewal 3.5 months previous, and they still had not completed review of her benefits. They had not provided me any information about whether she was eligible for the program again. And I was calling every day, to get updates. And ultimately, what I ended up doing, and this was lucky, honestly, I will admit this, the PAN Foundation had a grant that opened up for chronic ITP. And so I was able to call her, enroll her in that grant program, and then I had a prescription sent down to our pharmacy, which we were able to fill that day for her. And so she did not have a relapse. But I admit, I'm the first to admit that those kinds of challenges where everything seems like it's a dead end are really, really difficult to deal with. Does that sort of answer your question? I mean, sometimes the answer is no, unfortunately.
Because you are beholden to the organization that you work for. And it just seems like you have all this information that you use to help your demographic, people who are in your system, and you've got all this information that is so applicable to other people, and you've done all this work. How do we take advantage of what you have learned, people like you?
I think
because there's independent people like
yeah,
we get calls and we need the knowledge that you have. What are we doing?
I think, one of the biggest resources we have, again, is that sort of specialization model. So I know that not everybody's going to be able to do that, right? A lot of times it's like an alpha split or some other, a referral queue, and you just take whatever comes in. I think my answer would be that this is working really well for us. And if you can do things at your particular institution or organization to mirror some of this, I think you'll see huge benefits, because I am the first to admit, if I were to get a request for something for rheumatology, I would be like, no, I don't know what to do. Like, send it to the rheumatology clinic. And I can do that because they have people there, that help navigate that. So that is, I do admit that is one sort of thing that I am insulated from, in a sense. But I do really believe in this model. Like I said, we have a research project that we are working on to help advocate for this more, because it is working. And even though it has shortcomings, I think those shortcomings are more easily navigated than just, a random influx of referrals for any disease, any drug, any time, because that requires a lot of research before you even know where to start.
Anybody else?
Yeah.
Question. When you were looking to justify the success of your program, were you able to pull those data points out of your EMR out of that to reduce the faster turnaround time?
So yeah, that is actually part of the project that we're working on. We had a data analyst that works at the University of Utah help us pull a lot of that information from the EMR, and it's a graph that just goes like that, or well, I guess like that. But yeah, so we do have those numbers, and hopefully we can get this published. We want to publish it in a peer-reviewed journal at some point, but the pandemic really threw a monkey wrench in that, because we just had to put all side projects aside, just because of challenges with additional things that we had to take care of, like setting up remote work. Increased patient load. Honestly, the hospital was always full of people needing medication. So yeah. Anything else? I'm sorry, I've probably gone way over.
You're good, actually.
Hey, well, thank you guys for having me. I really appreciate it.
Who are you?
Thank you for your help.
Looking at your schedule, I don't know if you'll be able to come hang out.
Well, I think you're fine.
Because it's